Good afternoon and welcome to ICE Webinars, a cool place for hot topics. ICE Magazine is proud to bring our monthly webinar series to the imaging industry. ICE is a community that directly links nearly 7,000 imaging professionals with a monthly magazine, online community, an annual conference, and now a monthly webinar series. ICE Webinars would like to thank our sponsor, CareStream. CareStream is passionately committed to doing all the right things to help our customers be successful. They provide high-value technology, products, and services through engaged employees who drive continuous innovation and operational excellence. The work they do matters. Medical providers from clinics and single hospitals to large healthcare networks are upgrading their radiology capability using their systems. From developing X-ray products for general radiography, intensive care patients, pediatrics, sports medicine, dental practices, or veterinary hospitals to providing non-destructive testing systems to ensure airplanes, bridges, and pipelines are safe, and much more. For more information, please visit carestream.com. Today's webinar is eligible for one ARRT Category A Continuing Education Credit by AHRA and is approved for one CRA credit. To obtain your continuing education certificate, please complete the post-webinar survey. More details will be available on this after today's webinar. We're excited about today's presentation featuring Lori Barski, Ron Muscosky, and Jim Sehnert. We'll start the presentation with a quick video. Lori, you may begin whenever you are ready.
Artificial intelligence, AI. It's a term that's on everyone's mind and often comes up in everyday conversation. But what exactly is it, and how does it work? Artificial intelligence is everywhere, from ordering a cup of coffee at your favorite bistro to utilizing life-saving algorithms in the back of an ambulance on the way to the ER. This is where Eclipse comes into play, taking AI out of the abstract and putting it into everyday action. Eclipse is the engine that powers our imaging software, adding value and delivering measurable results in image quality, efficiency, and productivity, all thanks to AI. But how do we do that in the real world? How do we put AI to work? Let's start with imaging intelligence, which leverages AI and proprietary algorithms, delivering superb image quality and unrivaled diagnostic confidence. Next, workflow intelligence that revolutionizes healthcare. AI automates manual tasks, streamlines workflow, and supercharges productivity, leading to a higher level of patient care. And finally, analytics intelligence that delivers a digital dashboard, a consolidated way to view all performance metrics, to review and analyze results, and develop critical improvement plans. So the next time you use an app to order a cappuccino, think about how AI made that drink possible. Think about the AI behind the drink, and know the power of Eclipse with AI is doing the same, working behind the scenes on every image it manages to improve image quality, efficiency, and productivity. Eclipse with AI. That's intelligence in action.
Hi, I'm Ron Muscosky. Using AI in radiology imaging is not entirely new. CareStream has been incorporating AI in our image processing for years. As you saw in the video, our software powered by Eclipse uses artificial intelligence and plays a key role in our image processing and workflow efficiency features. We refer to this as intelligence in action, as our software uses proprietary algorithms as well as AI that delivers actionable, measurable results to provide a higher standard of care. Today, we will explore how AI and other algorithms are used in our image processing features to provide incredible images to help enhance diagnosis and improve treatment planning. Next slide, Lori.
Yes.
Eclipse is the engine behind our innovative image processing software. At its heart, Eclipse uses proprietary algorithms to provide automated and robust image processing that delivers superb image quality and consistent presentation. Eclipse is the foundation that enables numerous image processing features and options. Dual energy, digital tomosynthesis, and smart noise cancellation are our latest offerings available for the DRX Evolution Plus. I will now turn it over to Lori to cover our EVP Plus image processing.
Thanks, Ron. EVP Plus has utilized AI techniques since its inception, and this graphic highlights components within the EVP Plus system, which uses AI technology. EVP stands for Enhanced Visualization Processing. Raw 12-bit log image data is analyzed for high-frequency grid lines, and an expert system is employed to analyze frequency spectra for both detecting and suppressing the grid. Segmentation and analysis has many purposes in EVP+. One stage involves utilization of a support vector machine to automatically orient chest images head up to improve technologist workflow. Another function within segmentation and analysis performs edge classification, coupled with an expert system, to identify pixels in the image that correspond to collimator blades. A black mask is created and applied to the collimated regions to reduce viewing flare. Rendering is a multi-stage process of predicting image processing parameters from the segmentation results, constructing a tonal curve, breaking the image into frequency bands, adjusting the gains on the bands according to the predicted parameters, recombining the bands, and then applying the tonal curve. Parameter prediction takes image features and calculates those parameters based upon supervised learning using the method of linear regression. Now, Jim is going to highlight the advanced visualization capabilities in Eclipse.
Thank you, Lori. In addition to our outstanding EVP Plus processing, Carestream also offers processing algorithms for advanced visualization. These advanced visuals, also known as companion views, are images processed for a specific interpretation task. These algorithms use sophisticated image analysis, multi-frequency enhancements, and grayscale transformations to accentuate features of interest, such as edges, lines, and fine textures. Now, as we advance through this presentation, please note that the image quality of the pictures will vary depending on your internet connection and your display quality. Tube and line enhancement is an example of an advanced visualization designed to help in locating tube and line tips. Here, the image processing is tuned to highlight linear features and improve visibility in underpenetrated regions, such as the inferior mediastinum and the subdiaphragm region. The enhanced image improves the conspicuity of devices such as feeding tubes, endotracheal tubes, and central catheters. In the image on the right, the central line tip can easily be seen positioned in the superior vena cava. Next slide. Here's an example of an advanced visualization designed to enhance the appearance of a pneumothorax or collapsed lung. When a pneumothorax is present, edge sharpening helps to accentuate the outline of the visceral pleura, and texture enhancement helps to distinguish the lung markings or lack thereof in the case of a pneumothorax. The enhanced image on the right clearly shows a lack of vascular markings in the upper left lobe, which is indicative of a pneumothorax. Next. Bone suppression advanced visualization uses a powerful form of machine learning called a random forest, and this is to suppress high contrast bone structures that overlap the lung region. And this is all done while maintaining the same level of contrast and detail as in the original image. This view is intended to help the clinician find and interpret soft tissue abnormalities associated with lung disease. In the example shown here, there is a large CT-confirmed abnormality behind the right clavicle and top rib. As shown in the image on the right, the shape and size of the abnormality are much easier to see after bone suppression has been applied. Next. So now let's discuss our latest image processing technology, which is rooted in the latest AI technology. Smart noise cancellation, or simply SNC for short, is based on a deep learning convolutional neural network that predicts noise in a radiographic image. This predicted noise is then subtracted from the original image, resulting in a cleaner look. Next slide. So here is an example of SNC applied to the image of a neonatal patient. On the left is the original capture. In the middle is the noise predicted by the deep learning model. And on the right is the noise reduced or cleaned image. What should be noted here is that subtraction of the noise has little to no impact on the anatomical detail. And this is unlike traditional noise cleaning techniques, which typically uses some form of image blurring. So on this screen, this is the same example as we showed on the previous slide, but at a higher resolution to better appreciate the differences between the images before and after SNC has been applied. On the top right of the slide are the technique settings used for the acquisition. Next. Here is an example of a pediatric arm. You can see from the SNC image on the bottom how the soft tissue is cleaned up and the improved appearance of the cortical bone. Next. Another example of SNC, this time applied to a long length acquisition. As seen in the magnified sections, the noise is cleaned up significantly while maintaining excellent detail contrast throughout. This elbow exam was acquired at a very low exposure. You can see on the right how the trabecula of the bone is preserved, and I would say is even more prominent after SNC has been applied. Next. And here is a crop section from an AP lumbar spine exam. Again, SNC cleans up the noise nicely, but also notice how well sharpness is preserved in the wire mesh of the venous stent. Smart noise cancellation is a tool that stands alone well on its own. However, its real strength is in how it can be combined with other image processing features. For example, by combining SNC with our smart grid processing option, we can raise the bar in image quality. Smart grid processing was developed to suppress the effects of scatter in images that are acquired without an anti-scatter grid. It improves the anatomical contrast and provides the image quality comparable to an image that was acquired with a grid. On this screen is an example of a pelvis exam acquired without an anti-scatter grid. The lack of contrast seen in the image on the left is caused by the X-ray scatter, which makes the image, which masks the image detail and adds a significant amount of noise. On the right is the same acquisition, but this image was processed through Smart Grid and SNC. And as you can see, the contrast is greatly enhanced. Next. Now let's magnify into the left femoral head. The increased resolution of these magnified views better depicts how Smart Grid brings out the bony detail, while SNC keeps the noise in check. And here is another example of an exam acquired without a grid. Again, as shown in the image on the right, the image processed with Smart Grid and SNC greatly improves overall contrast. Next. Magnification into the upper left lung shows the significant increase in the subject contrast of the bone, cardiac, and lung tissue, all without enhancing the noise. So now let me turn control back over to Lori, who will talk about some reader studies that show the benefits of SNC in terms of improved image quality and dose reduction potential.
Thanks, Jim. So we're going to talk about the clinical evaluation of smart noise cancellation, and 2 reader studies were performed. I'm first going to discuss the results of the reader study that is measuring the image quality impact of SNC, where the same image was processed with and without SNC. I call that the isodose study. That's going to be followed by a summary of our reduced dose reader study. So the greatest risk of denoising medical images is the possibility of inadvertently removing important information. The assessment of this risk can be accomplished by performing a controlled observer study that forces careful before and after pairwise evaluation of image quality based on expert human observers with suitable domain knowledge. The isodose study had 2 objectives. The first was to demonstrate that images processed with SNC have a quality level that is equivalent or better than images processed with EVP Plus alone. Preference was measured using a relative 5-point scale, and diagnostic quality was measured using a 4-point absolute scale. The second objective was to demonstrate that SNC processing is safe and effective. 2 U.S. board-certified radiologists with a specialty of diagnostic radiology evaluated 67 pairs of human clinical and cadaveric subjects captured on 5 detector types, GOS and cesium panels from the DRX1 and DRX Plus family of detectors. Various exams, patient sizes, and exposure levels were used in the study. Each detector type has its own unique CNN. The image pairs consisted of an image processed with default EVP Plus processing, including traditional noise suppression, which is standard with EVP Plus, and then the image processed with smart noise cancellation, with the EVP Plus processing modified, such that noise suppression was disabled and the sharpness was tuned to be consistent with the sharpness appearance of the default processing. Images were randomly placed left or right and were presented in random ordered work lists with the retreatment conditions blinded to the readers. Each radiologist had a different work list order, and the readers were encouraged to adjust window width and window level to fully explore and compare the images. The readers first rated the pair for preference using 5-point relative scale tied to diagnostic confidence. A negative rating indicated that the image on the left was preferred, and a positive rating indicated that the right image was preferred. The magnitude of the number, 1 or 2, indicated the preference level, and readers were instructed to use the preference scale such that slightly preferred or 1 ratings would most likely not impact diagnosis or their diagnostic confidence, and strongly preferred or 2 ratings would likely impact the diagnosis. Analysis of the ratings utilized a value of 0.5 as a difference that matters. Next, the readers rated the left and right image for overall diagnostic quality based upon the Radlex scale shown. A difference that matters in diagnostic quality is 0.5, and the safety and effectiveness threshold is a diagnostic quality rating greater than 2. Comments were also recorded. After the ratings were completed, ratings were decoded such that positive values indicated favor for SNC. For example, if the pair being rated has the SNC image on the left and the EVP Plus image on the right, and the rating is a -2, indicating that the preference is for the left image, upon decoding, this case will have a preference rating of +2. The distribution of IEC exposure indices in the study ranged from 75 to greater than 225, which corresponds to ISO speed classes of 1,000 to 200 speed. Most of the exams had IEC exposure indices ranging from 100 to 200. I'll begin with the descriptive statistics of the data. The mean preference of 1.3, positive, indicating favor for SNC, is much greater than the difference that matters, 0.5, indicating clear preference for the smart noise cancellation processing. The mean diagnostic quality rating for SNC is 3.6 and is significantly higher than the diagnostic quality of EVP plus processing alone. The median SNC diagnostic quality rating was 4, indicating a diagnostic quality of exemplary. And the non-overlapping confidence intervals of the diagnostic quality ratings implies that SNC images are significantly higher in quality than the EVP plus images. Greater than 89% of all preference ratings showed slight to strong preference for SNC. There were no images rated as non-diagnostic in the study, and most responses were diagnostic, and none of the SNC images were rated below 3, diagnostic. The contingency table is a handy way of comparing raw diagnostic quality RADLEX image ratings of the EVP plus processing versus SNC processing. And from this table, we can see, as indicated by all the zeros above the shaded diagonal, there were 0 instances of EVP plus processing alone being rated higher than EVP plus with SNC. There were 12 instances of images processed with EVP plus alone being rated limited, but with SNC applied were rated diagnostic. And similarly, there were 4 instances of images processed with EVP plus alone being rated limited, but with SNC applied, they were rated exemplary. And then there were 70 instances of images processed with EVP plus alone being rated diagnostic, but with SNC applied were rated exemplary. These increases in diagnostic quality, 64.7% of the cases, provide strong evidence that the EVP plus with SNC is superior. In this chart, the red center line represents the average preference of the radiologists, and their mean preference response is similar. All mean preference responses were above 1.0, favoring SNC. And in the analysis, it was determined that readers, detector types, and the exposure speed were not significant sources of variability in the study. Now I'm going to share the inferential statistical results. The paired t-test was used to evaluate if its difference in RADLEX ratings was greater than a difference that matters, that is 0.5. The results demonstrate that the mean RADLEX difference clearly is greater than 0.5, and therefore we conclude at the 95% confidence interval that SNC processing yields RADLEX ratings significantly higher than EVP plus processing alone. The one sample t-test was used to determine if mean preference ratings were in favor of SNC processing at a level that matters, that is greater than 0.5. This test demonstrates that the mean preference rating is greater than 0.5, and we conclude at the 95% level that SNC processing is substantially more preferred over the EVP plus processing alone. The one sample t-test was used to test the safety and effectiveness of SNC processing, testing if the mean SNC RADLEX rating is greater than 2, limited, and at the 95% confidence interval, clearly SNC processing is safe and effective with a mean rating of 3.56. Equivalence inferential testing was part of the statistical analysis plan of the study. However, due to the clear signal that SNC is both strongly preferred and is significantly greater in diagnostic quality than EVP plus alone, equivalence testing was irrelevant. The comments of the radiologists are shown in different colors. Bold comments are from cases where the EVP plus images was rated a 2 and the SNC image was rated 4. A common theme emerged: SNC processing provides better clarity. So in conclusion, for this isodose study, smart noise cancellation is clearly preferred over EVP plus processing. It produces images with higher diagnostic quality. It is effective over a wide range of exposure levels and detector types, and it removes noise without impacting high-frequency detail, something that traditional noise suppression techniques have failed to achieve. And as one might expect, these results are highly suggestive of potential dose reduction, which is what the next study is all about. The primary objective of the reduced dose study was to demonstrate that reduced dose images processed with SNC delivers radiographic quality that is as good as or better than corresponding images acquired at nominal dose processed with EVP plus alone. And then a secondary objective was to evaluate reduced dose image quality as it relates to detector type, image type, and exposure level. The design of this study has many similarities to the ISODOSE study previously mentioned. 3 board-certified radiologists with their specialty of diagnostic radiology evaluated 60 pairs of human clinical and cadaveric subjects captured on the 5 detector types, GOS and cesium panels from the DRX1 and DRX Plus family of detectors. And various exams, dose reduction levels, and patient size were used in the study. Each detector type has a unique CNN, as I had mentioned previously. So 2 types of reduced dose images were included in the study. First, independent cadaver acquisitions across a range of dose reduction levels were used for the Plus family of detectors. Clinical results, or clinical reduced dose images, were simulated at prescribed dose reduction levels, which were dependent on the scintillator type for all detector types. Noise simulation was employed because of the obvious desire to minimize double exposing of patients. The same noise simulation methodology which used to inject noise into our training images of the CNN was employed on a random assortment of clinical images collected under trade trial agreement. Image type was a factor in the study to determine if these different types of images were significant sources of variability. So each image pair consisted of a nominally exposed image processed with default EVP+, including traditional noise suppression which is standard, and the reduced dose image ranging anywhere from a 35 to 60% dose reduction processed with smart noise cancellation with the EVP+ processing modified such that noise suppression was disabled and the sharpness was tuned to be consistent with the sharpness appearance of the default processing. And images were randomly placed left and right, presented in random work list orders, and treatment conditions blinded to the readers. Radiologists had different work list orders, and the radiologists were encouraged to pan and zoom and window level to really explore the images. Like the previous study, the readers first rated the pair for preference using the 5-point relative scale tied to diagnostic confidence, and then rated the left and right images for diagnostic quality using the RADLEX scale shown. And of course, comments were recorded. And then after the ratings were completed, the ratings were decoded using the same methodology described in the first study. This histogram of nominal exposure indices demonstrates a bimodal distribution, which is consistent with the 2 types of scintillators associated with the panels used in the study, gadolinium oxysulfide and cesium iodide. The lower peak corresponds to the cesium images, which is typically 400 speed nominal exposures, and the upper peak corresponds to GOS images, typically corresponding to a ISO speed of 330. From the descriptive statistics of the data, the mean preference of 0.67, positive, indicating favor for reduced dose with SNC, is greater than the difference that matters, 0.5, indicating preference for reduced dose images with smart noise cancellation processing. This difference in preference rating between the image types, that is the cadavers versus the clinical images with simulated noise, is not significant in this analysis. The mean diagnostic quality rating for reduced dose images with SNC is 3.54 and is higher than the diagnostic quality of the nominal dose images processed with EVP+ alone. Differences in RADLEX ratings between the image types is not statistically significant. The median diagnostic quality rating of reduced dose images with SNC was 4, indicating a diagnostic quality of exemplary. And the non-overlapping confidence intervals of the diagnostic quality ratings indicates that reduced dose with SNC images are significantly higher in quality than nominal dose images with EVP+. 93% of the preference ratings reflected no preference or preference in favor of the reduced dose images with SNC, and 60% of the preference ratings were slightly or strongly in favor of the reduced dose images with SNC, suggesting overall preference for the reduced dose images with SNC. And preference ratings by image type suggest that the preference response is similar between cadaver types of images and clinical images with simulated noise. Here we observe that there were no instances of images rated non-diagnostic. Greater than 98% of the reduced dose plus SNC images were rated diagnostic or higher, and greater than 54% were rated exemplary. Also, most of the nominal dose images were rated diagnostic, whereas most of the reduced dose images were rated exemplary. And finally, when the distributions are examined by exam type or image type, similar trends are demonstrated. From this chart, we observe that radiologists consistently responded similarly, or they consistently responded the same, regardless of the image type. And on average, the reduced dose images with SNC are consistently rated higher in diagnostic quality. These are plots of mean preference as a function of the major factors of the study. Top left illustrates that reader variability is a significant source of variation due to reader A, the confidence interval not overlapping the other confidence intervals. And then all the readers preferred SNC on reduced dose images over nominal images processed with EVP Plus alone. The remaining plots illustrate that image type, detector, and percent dose reduction are not significant factors. However, due to the small number of samples at the 60% dose reduction level, dose reduction conclusions are restricted to levels less than 55% or less. This contingency table is a handy way of comparing the raw RADLEX ratings as we had done before. And here we observe that 178 out of 180 paired ratings, which is 99% of the data, the reduced dose images with SNC were rated the same or higher than the nominal dose images processed with EVP Plus alone. And 54 out of 180, or 30% of the paired ratings, were instances of the reduced dose images with SNC being rated higher than the nominal dose images. This data suggests the reduced dose images with SNC are superior. Now for the inferential test results. The paired t-test was used to evaluate if the difference in RADLEX ratings was greater than 0. The result demonstrates that the mean RADLEX difference is greater than 0, and therefore we conclude at the 95% confidence interval that SNC processing on reduced dose images yields RADLEX ratings greater than 0. And while the difference may not be clinically impactful, greater than our 0.5 threshold, the SNC processing on reduced dose images produces images with diagnostic superiority over the nominal images. The one sample t-test was used to determine if the mean preference ratings were in favor of SNC processing at a level that matters, that is greater than 0.5. And this test demonstrates that the mean preference rating is greater than 0.5. So we conclude at 95% confidence that the SNC processing on reduced dose images is substantially more preferred over nominal dose images with EVP Plus processing alone. And then the one sample t-test was used to test safety and effectiveness of SNC processing, testing if the mean reduced dose SNC RADLEX rating is greater than 2, limited. The 95% confidence interval, SNC processing is safe and effective with a mean rating of 3.56. Equivalence inferential testing was performed as part of the statistical analysis plan on both preference rating and paired RADLEX ratings, testing ratings within the interval of -0.5 to +0.5. Equivalence was not demonstrated for the preference ratings, and this is not unexpected since the mean preference was 0.67, which is greater than the upper bound of the confidence interval. Equivalence testing using pairwise RADLEX ratings resulted in equivalence being demonstrated. And it is reasonable to state that the low dose images with smart noise cancellation yields image quality that is as good as nominally exposed images with EVP Plus alone. So in conclusion, reduced dose images processed with SNC are clearly preferred compared to nominal dose images processed with EVP Plus alone. SNC on reduced dose images produces diagnostic quality that is as good as or better than nominal dose images. And SNC is safe and effective across a wide range of exposure reductions and is effective across all detector types. So now I'll hand it back over to Ron to wrap things up.
Thank you, Lori. Smart noise cancellation has a number of benefits, including improved anatomical clarity, preservation of fine detail, and better contrast to noise ratio for images acquired at a broad range of exposures. It enables a reduction in radiation dose. This is especially important in neonatal and pediatric imaging, where imaging at the lowest possible dose is critical. It also allows adjustment for the amount of noise cancellation and exposure to meet the desired image quality. It can also alleviate physician fatigue with easier to read radiographs and promises benefits in gridless imaging when combined with our smart grid option, where the removal of scatter typically leads to an increase in noise appearance. For additional detail, we will be sending you a white paper that goes into more depth on the algorithm, objective and subjective performance and clinical evaluation results. Next slide. As we have shown, our software powered by Eclipse uses AI to provide intelligence and action. Thank you for your attention, and we will now open up the session for questions and answers.
Thank you, Lori, Ron, and Jim, for this valuable information. As a reminder to our audience, if you have a question for the presenters, please use the questions feature on your GoToWebinar dashboard. We do have several questions that have come in already, and we'll start with those. Our first question for the presenters is, what products is SNC available for?
I can take that. Yeah, so SNC, or Smart Noise Cancellation, is available on our DRX Evolution and DRX Evolution Plus room products. It will be added to other products in upcoming releases, but those are the two products it's available on today.
Thank you, Ron. Our next question is, can SNC be added to an existing system? And if so, is any additional hardware needed?
I can answer that one as well. Okay, so yeah, SNC can be added to any DRX Evolution and Evolution Plus system that has been upgraded to our ImageView software platform. Regarding the hardware, depending upon your current hardware that's installed, it may require a new computer with GPU, but that certainly is dependent upon what's currently installed.
Great, okay. Our next question that's come in is this feature available on all body parts and views?
I can answer it. Yeah, so yes, this feature is available for all general radiography images, for all patient sizes, body parts, and projections. It also supports stitched LLI images as well. Dual energy and digital tomosynthesis images will be supporting in an upcoming release. Those are some of our advanced applications that we had mentioned earlier in the presentation.
All right, does SNC work with both physical and virtual grids?
Or do you want to take that one?
Oh, sure. Yeah, yes, it does. The virtual grid, Jim highlighted it in his talk, and with standard grids, we filter them if they have an appearance in the image, and then we suppress the noise beautifully.
Right, and just to clarify that the virtual grid that you're referring to in their product is called Smart Grid.
Mm-hmm.
All right, thank you. Our next question is, how do you recommend a hospital implement SNC to maximize its benefits?
You want to take that, Ron?
Go ahead.
I can't
Okay.
at this moment.
Okay, yeah, so I'll hit, yeah, sure. Noise is a subjective quality, and while most radiologists find it to be a nuisance, some radiologists do expect to see noise in certain parts of the image to confirm adequacy of exposure. Since beauty is in the eye of the beholder, our recommendation is to start gradually, first by using SNC as default level on images acquired using the standard exposure techniques. After the radiology staff are comfortable with SNC, then the radiographers can work with the physicists or other decision authorities and gradually and or systematically begin to lower the dose to the level best suited to the institution. Dose reduction amount is relative to where the institution is currently operating at.
All right, great. Our next question is, do users have the ability to adjust the amount of noise cancellation?
Sure, let me take that one. So the facility has the full control of how they utilize noise cancellation and change the exposures to meet their desired needs for image clarity to better optimize image quality and radiation dose. So the user can adjust the amount of noise removed as a percentage of the magnitude of the overall noise field. So for example, if the user selects 70% of the noise field, that noise field is scaled by 70% and then subtracted from the image. In this way, that the users have the full capacity to go from basically zero noise reduction to full noise reduction based off of their preferences.
Thanks, Jim. Our next question is there any change to our current workflow to use this feature?
I can take that. There's no change to the current workflow. After an exposure, the preview image is displayed as it is today, but without smart noise cancellation. And then the full res image is then processed on box in real time with smart noise cancellation applied. So on average, the full resolution image with smart noise cancellation is applied a couple of seconds longer than without smart noise cancellation.
Thanks, Ron. What detectors are supported?
Jim, do you want to take that?
Sure. For the DRX evolution, the detectors supported are the DRX1 and the DRX Plus family of detectors, and these are supported with both the GOS and the cesium iodide scintillators. Oh, and also supported will be the Lux detectors, which will be released in the latter half of this year.
Yeah.
Sorry.
All right. Does SNC change the file size of images stored to PACS?
Want to take that, Jim?
Sure. Yeah. So delivering an image to PACS, if one is using a lossy compression scheme, you'll see reductions in file sizes on the order of 10 to 15%. And simply because by removing noise from the image, you're sort of removing the what's called the entropy in the image, which makes image more or less incompressible. So, but only with lossy compression technologies will you realize that benefit in file size reduction.
Mm-hmm.
What is the size of the CNN networks in terms of dimensionality or the number of weights?
A couple of things there. The architecture of the network glossed over in the presentation is called something called a UNet, and in technical terms there are 21 convolutional layers, but in terms of the number of parameters that are needed to fit the model to go from input to output, there are 1 million parameters.
How did you address bias in the data set?
Okay, I'll take that one. We used over 4 million images of various body parts, projections, patient sizes, and exposure values to train our neural network model. So by testing over this wide variety of images, we believe that we have really reduced the potential to introduce bias into this model. And with our large testing data set, and with any new incoming data that we've tested the algorithms on, we've never seen a performance difference in terms of the qualitative characteristics of the noise reduction. So overall, we see a uniform noise reduction regardless of the types of images that we're seeing coming in from the field.
Mm-hmm.
All right, our next question is, what amount of training is needed for the technologist in using this software?
Yeah, I can take that. So as far as additional training, I mean, it's very little additional training to what they have today. I mean, there are some additional configuration settings to look at for applying smart noise cancellation, and also some work to occur with the physicians as well to make sure that the image quality, the noise cancellation, and the exposure settings are what they're expecting. So we do add some additional time, but it's really you know, very little compared to the overall training that's typically provided to the customer at installation time. Laura, do you have anything else you'd like to add to that?
No, my understanding, it's pretty much seamless.
Mm-hmm.
All right. Thank you again, Lori, Ron, and Jim, for your time today and for a great presentation. I'd like to encourage everyone to visit today's sponsor to learn more about the services they provide to our industry. Please visit carestream.com. As a reminder, you can obtain your continuing education certificate by completing today's post-webinar survey. The survey will be emailed to you 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE credit. You'll be able to download your certificate immediately after the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. ICE Magazine is proud to bring you our monthly webinar series. Thank you for being part of the ICE community. For more information about our upcoming ICE webinars, please visit icewebinars.live. Thank you all for coming and have a great day.
Take care.
Thanks.
Thank you.